Okay, we are going to get started at it's 12:02, and this is the first lecture of our 2026 series for the McGill Palliative Care National Grand Rounds. Thank you for being here. I know people will trickle in, and I hope people saw the instructions about how to use the translation if necessary or if helpful. I want to start by thanking Stephanie Gingras, Dr. Stephanie Gingras, who really led us as a course director through the first year of this program, and has moved on to other responsibilities. But we were so grateful for all the work that she did to help bring this to fruition in the first year. And some of the feedback that we had from our first set of lectures last year was that there was a lot of time spent listening to the accreditation information that is sort of necessary that we must present with every lecture. And so we've taken a different approach this time, and we've pre-filmed it. And we've sped it up a little bit. So I hope people won't mind if they hear a slightly high-pitched voice going through some of the accreditation-related information, as well as our land acknowledgement for this lecture. So I'm going to start that off and before introducing our speaker. Whoop.
We acknowledge the contributions of the Scientific Planning Committee. The members of this committee and their relevant declarations include Dr. Justin Sanders, who has relationships with La Maison Saint-Raphael, the American Society of Clinical Oncology, and Connections, Inc., and who has received honoraria and grants in the past 2 years from the Oregon Health Sciences University, Pancreatic Cancer Canada, the Canadian Institute for Health Research, and the Rossi Cancer Network. Dr. Zelda Freitas reports grants and relationships with the McGill Council on Palliative Care, Nova Montreal, and the Canadian Centre for Caregiving Excellence. Dr. Naomi Goloff reports relationships with the Canadian Society of Palliative Medicine and grants from the Kindred Foundation and l'Association Québécoise des Soins Palliatifs. Dr. Olivia Nguyen acknowledges an association with la Société Québécoise des Médecins des Soins Palliatifs and a research subvention from la chaire de la famille Blanchard pour l'enseignement de la recherche en soins palliatifs. And Dr. Arjuri Simikalis discloses a relationship with and grants from the Shriners Hospital for Children. Doctors Janelle Walsh and Oral Shuker have no conflict of interest to disclose. This series is made possible by unrestricted education grants from the Cedars Cancer Foundation, the Douglas Hospital Foundation, the Hope and Cope Wellness Center, the Jewish General Hospital Foundation, the McGill University Health Center Foundation, the Montreal General Hospital Foundation, the Montreal Institute for Palliative Care, a branch of the Teresa Deller Palliative Care Residence, the Montreal Children's Hospital Foundation, and the Montreal Neurologic Institute, Pallium Canada, and the St. Mary's Hospital Foundation. Special thanks to the Department of Family Medicine at McGill University for their in-kind support. Here we present a strategy to mitigate potential bias. The overall program learning objectives are as follows: to review innovative approaches for the implementation of palliative care in different settings, to assess strategies to address the most important challenges in palliative care today, and to appraise the latest research in the field of palliative care.
All right. Hopefully people could understand that. So my name is Justin Sanders. I hold the Cappy and Eric M. Flanders Chair of Palliative Care here at McGill University. Thank you so much for your attendance today in person and virtually. Our speaker today is Dr. Linda Watson. Dr. Watson has been an oncology nurse in Calgary, Alberta for over 30 years. She's held a variety of nursing and interprofessional leadership and research roles within the Cancer Care Alberta Provincial Program and currently holds the role of Executive Director, Supportive Care Services and Patient Experience. Dr. Watson also holds an adjunct professor position with the Faculty of Nursing at the University of Calgary and is past president of the Canadian Association of Nurses in Oncology. She also has recently completed a 4-year term on the board of directors for the International Society of Nurses in Cancer Care. Personally, I'll just say that I think that the work that Dr. Watson is doing is really at the forefront of palliative care and really at the leading edge of the state of the science. So I'm really delighted that she could be here today. So welcome, Dr. Watson.
I'm so pleased to be here today. It's a beautiful part of the world that I haven't had the privilege of exploring very much. So the opportunity to be here in person is been very greatly appreciated. And I'm excited to share my knowledge from what we've been doing in Alberta with you. So I don't have any conflicts of interest to declare. These are the framework, which I think was in here before my presentation went in. So I will talk about my learning objectives. So first, I'm going to just really help you understand how our provincial cancer jurisdiction in Alberta has integrated patient-reported outcomes into routine care to improve capacity for targeted symptom management. Then I'm going to walk us through some trends, patterns, and predictive capacity of using that routinely collected pro data in relation to cancer patients who are living with advanced cancer and receiving non-curative treatments. Um, and then I'm going to wrap up our conversation with efforts that we have underway to harness this data and our provincial electronic medical record, which is the EPIC system, to develop decision support tools to identify patients who would benefit from early palliative interventions. So it's me. I want to acknowledge that the work I'm going to talk about has been funded primarily by the Canadian Partnership Against Cancer. We've held several different implementation grants from CPAC. And then also, most recently, I've been collaborating with Dr. Ian Sinaraja, who used to be in Alberta, but now he's out in Ontario, I believe in London. He received a Canadian Cancer Society Emerging Scholar Grant, improving cancer survivors' access to timely palliative care, and looking at validating and building triggers in the EMR with real-world evidence. So Ian and I, Dr. Sinaraja and I have been collaborating using our patient-reported outcomes data to underpin that decision-making around what could those decision support triggers in the EMR be. I want to also acknowledge Dr. Lisa Barbera, who was quite a leader in the patient-reported outcome space in Ontario, who has now moved to Alberta, and she co-leads our provincial patient-reported measures advisory council with me. Our patient and family advisory working group has been instrumental in the design of our work as well as working closely with our IT system to build everything into our EMR. So a little bit about where I work. Alberta is a province of about 5 million people, and our cancer program in Alberta is responsible for all ambulatory oncology care delivery and some inpatient cancer care across 17 sites in the province. So the names you see on the map are all places we have a cancer facility, and not all of them are created equal. I would say we have 2 tertiary cancer centers, one in Edmonton, one in Calgary, that are full service integrated research care delivery facilities. And then we have 4 regional cancer centers, which primarily treat more common types of cancer, so breast, lung, GU, GI, and hematology cancers. But if you had something like gynecological cancer or head and neck cancer, you would still have to go to the tertiary centers to be treated for that. And then we have 11 rural community cancer clinics where people can get their infusions closer to home. So all of those patients also have to travel to either a regional or a tertiary site to have an oncologist set their care plan, but then they can get treatment closer to home. We have about 3,000 staff and physicians across Cancer Care Alberta, and annually we see about 23,000 new cases of cancer every year in the province of Alberta, so pretty big volume. So specifically, I'm going to talk about work I have led over the last 15 years to integrate patient-reported outcomes into routine care in ambulatory oncology. And this is really fundamental work that has now allowed us to step into the space of using that data to identify patients that have high palliative care needs and building those EMR flags. So one goes hand in hand with the other, so we have to start at the beginning. And this work is not for the faint of heart. So I don't know how many of you have been involved in trying to implement patient-reported outcomes into routine practice, but I would say that I have felt like a salmon swimming upstream for about 15 years. And I'm really happy to say we've come to a different place. It's not as hard anymore. It's more integrated, and I'm really excited to share that with you. And I look forward to answering any questions that you have about implementation and some of the things that we did. Obviously, I only have, 40 minutes, so it's a pretty high level overview of the work we've done, but hopefully it plants some seeds and we can have an ongoing conversation. Even when I'm back home, I'm happy to have consultations and help move your work forward. So in 2012 to 2016 was the first phase of our work, where we really focused on using a common symptom measurement tool and having standard practice around reviewing it, talking to patients, and making referrals. So I'm going to talk about that first. That piece of work allowed us to move into our second focused phase of work, which was really around, if you have common data points collected from patients and you have a common practice, how might you use analytics to show that data in a way that helps clinicians use it more seamlessly, have it at their fingertips, inform personalized care delivery? And from there, we moved into our most recent phase, which was the integration into a fully electronic EMR, which we use Epic, and that came with a tethered patient portal. So we now have a reality where patients can complete this from home. It flows into the EMR. Clinicians can look at it ahead of time. Yeah, I know. Sounds so simple, right? Like, why is... But there is a whole art of implementing and using data to drive the changes you need to see, which is hopefully what you will take away from this talk. All right, so let me start at the beginning. So obviously our goal of implementing patient-reported outcomes was around improving person-centered symptom management. What patient-reported outcomes really help us understand is, from the patient's perspective, what symptoms are they struggling with and how have they been changing, so that we can partner with patients to talk about what solutions might be helpful to them, making those referrals. And what I would say that in our system of care, we really have focused on nursing being the first reviewer of this information with patients, and then using it as a communication tool with our oncologists to help them understand what we need the oncologist to do that complements what the nurse brings to the table. So we in Alberta, in Cancer Care Alberta, we actually do the same core patient-reported outcome measure at all of these time points. At first consult, once per treatment cycle in systemic therapy, at select time points in radiation therapy, because patients are coming every day, so they don't really need to fill this out at all treatments, and then at all follow-up appointments. And what this has given us is a longitudinal trajectory of how patients experience symptoms and the kinds of care we need to align with those symptoms. So before we went, so our current state is now that we're on an electronic EMR. Patients can complete it in the portal, and I'll talk about that in a second. But before we went live with that, we didn't have a portal. So we used paper-based measurement. And our workflow looked like this. At check-in, the clerk would give the patient the paper form, the patient-reported outcome questionnaire. The patient would complete it in the waiting room. The patient would then take it into the clinic, where it was reviewed by the registered nurse, and the nurse would review it with the patient, talk about possible strategies for managing symptoms. The nurse would then step out of the clinic to meet with the physician before they go into the room. They would share what the key concerns of the patients were, what the actions the nurse was going to take, and what pieces the nurse needed the physician to follow up on. And then after the physician came back out, they would huddle about what other follow-up or referrals need to be made. So that was the workflow that we put in place. And really what came out of this, and what our clinicians really talk about, is that patient-reported outcomes is really a communication tool. That's how they see it. It's about communicating with the patient. It's about communicating with each other and understanding what activities are going to be helpful from a person-centered care delivery. Personalized medicine, this is about personalized care. But the critical point that I would stress over and over is that gathering this kind of information directly from patients must be followed by a clinical review and response. If your goal is to improve person-centered care and symptom management for the patient in front of you, there must be a corresponding review. So I think in lots of research studies, we collect patient-reported outcome measures because we want to evaluate at a high level, after the fact, how did this intervention affect patients' symptoms and experiences? When you're doing it in routine care, it really has to be embedded into the conversation, because if it's not, patients quickly say, this is not very helpful. I could complete this form and give you all this information of symptoms, but nobody helped me with what I was struggling with. And isn't that the purpose of me completing this? So that somebody can help me. And so that was a really huge part of our very, very early learnings. And if anybody wants the series of publications that have come out of this 15 years of work, they're all very available. If you just looked up Watson, you would find a whole whack of them. I have been very careful to publish on every step of the implementation and the key learnings, because I know that this is such an important area that so many of us across Canada and internationally are struggling to really crack that nut about how do you get it into routine care. So back in the beginning, we used ESAS-R. And so this is and I think that you're familiar with the ESAS-R here. And importantly, as I said in the beginning, this was really about talking about symptom management. The reason we used a generic patient-reported outcome measure, so not a disease-specific measure, was because our purpose was, what are the common symptoms that all cancer patients have? What are the services we already have that are underutilized? Because if patients are having symptoms and we have a supportive care team that's underutilized, we're doing something wrong. So that was the underpinning reason why we proceeded with ESAS, because it's such a good fit for supportive care. So just to give you that clinical view, when we did our implementation, we really worked on upskilling our clinical teams to really understand the basics of symptom management that they could undertake within the clinic. But then we used algorithms and cutoff points to really recommend referrals to our programs. So you can see that pain symptom of 7 and above, we would be recommending a referral to our pain clinic within Cancer Care Alberta. We have tiredness, we have a fatigue program at our rehab oncology program. So again, those recommendations, this is the kinds of symptoms and what you can do to get the patient connected to those. So we have dietitians, we have dyspnea clinic for shortness of breath, we have our psychosocial team for anxiety and depression, and then we have psychosocial and palliative for that sense of poor well-being, quality of life. And so this was really helpful, because the first thing we struggled with was our staff saying, well, if we ask these questions, what are we supposed to do about them? And this reality that we have all these services that weren't well understood was a very important beginning success. And you'll see in the middle, drowsiness and nausea, I don't have a referral source for those because it's clinical practice to manage those. So from that focus on, okay, so if we gather information from patients, we need a practice around reviewing it with patients and making appropriate referrals or reinforcing that care in the clinic. That allowed us to move into our second area of development, which was really about improving the utility of the information to our clinicians. So obviously we started with a paper form. And we got lots of feedback from oncologists and clinical care teams that a paper form isn't that helpful, because it can't show you what's changed. It can't show you what the symptom was before and directionality of that. You look at it and you think, okay, so 6 out of 10 on pain, but I don't know what their pain was last time. And so the prioritization of pain management depends on if this is a chronic pain they've been living with for years, or if this is an escalation and it's changing. And so we did a whole bunch of work in our past EMR, which was ARIA, where we designed a questionnaire where our clinicians could put that information in. So the patient completed the paper form. There was a very easy check boxes where the clinician put that information in, and then it pulled into their documentation. So again, carrot for our clinicians was, if you use this form, it will simplify your documentation because it brings all those symptoms right in, and then you just put your cursor beside it and say what you did. So again, really pragmatic thinking about why we did that. But the benefit of that was then we had discrete data points in the back end. We started to be able to work with saying, how might bringing this information back to the fingertips of our clinicians make it easier for you to manage their symptoms? So I just put a little screenshot of the tool that we created, which we call an individual trended dashboard. So it's specific to a patient and it shows their historical trends of what symptoms they've reported over time. And we worked with clinicians to do this, and really they said, like geographically on the line, make it visible if things are getting worse. Use color-coded colors to help me draw my eyes to things that are in that most severe category. So red, yellow, green, and you can see at a glance that this patient is not doing well. It's easy to interpret. You can see 9 out of 10 on lack of appetite. Shortness of breath is worsening. Depression is a 9 out of 10. Anxiety is an 8 out of 10. And well-being is at 7 out of 10. Worst ever being a sense of well-being is at that 10 out of 10. And so at a glance, you can see how much easier it is for clinicians to actually say, whoa, there's something significant going on with this patient. We need to think about making those referrals. So that was a huge piece of work that was enabled by having electronic data. And this is an example, demonstrating how having that trended symptoms over time. First, we had clinicians say to us all the time, patients always circle the same number. It's like they're always circling the same thing. They don't really think about it. This is an example of a patient. This is the same patient at 3 different points on their cancer trajectory. And you can see at a glance that the patient was doing very well at the beginning with symptom management. Really no scores above a 3 on that 0 to 10 scale. You can see in this midpoint of the disease trajectory, everything is creeping up. There's something going on, which quickly transitioned into the phase 3, which is that late stage of their symptom trajectory where everything is going into that red zone. And so this was one of the very first patients that really stopped us in our tracks when we saw this tracking to say, what's going on with care delivery? And I will tell you, we did a huge case review on this patient. This is a pancreatic cancer patient. We did a huge case review, and I want to just tell you, it was so sad to actually see that this patient was not connected to symptom management, or palliative services until that last visit, May 12th, and then died 3 weeks later. So this was the case that really started us thinking about the predictive value of PROS. When you see the trends that are getting worse and worse and worse, we need to take that information and think we should be doing something different. So, this is funky. This has changed the text on my screen, but it's very pretty with this fancy writing. So based on that case, we started to question whether we could, because clinicians were like, these graphs, so back to here, this is all good. And they had these nice trended graphs, but then clinicians say, it's too much data. It's too much information. Can you help give us just a quick flag to say, you must look at the symptoms of this patient because they're really struggling. And so we kind of started categorizing how, symptoms on one single day, how complex are the symptoms the patient is reporting. And so that really led us to the development of what we are calling a symptom complexity algorithm, which basically looks at all the symptoms the patient reports that day and categorizes the patient into high symptom complexity, which is basically like that graph on the previous slide. Most of the symptoms are above 7 that they've reported. Or a moderate symptom complexity, where most of the symptoms are in that 4 to 6 range, so that yellow category. Or low symptom complexity, which would have been what that patient was at the very beginning, where most of the symptoms are minor. And so symptom management is not the biggest part of what they need from us right now. And so because we had implemented ESSR across all of our populations, we had a plethora of data to look at. And so what we learned is that not all patients need more symptom management, which was a huge life-changing reality. When I could say to our oncologists, because there's no time. Don't ask me to do one more thing in our clinics. We're too busy. There's too much going on. It's like not all patients need more. Some patients need more. And what we saw was 60% of our patients across Cancer Care Alberta had low symptom complexity. They were actually doing well in the space of symptoms. And so if you had to, in a cost constrained or a resource constrained environment, if you have to make choices, those are the patients that are doing okay. So if you have to reallocate resources to actually have time to talk about symptoms and do symptom management, it should be the people in the moderate and the high category. Not to say we're cutting anybody off from care, because people in the low category could have needs as well, but it started to help us quantify that. So 40% of the patients were in that category of moderate or high symptom complexity, with only 15% of that 40% would be in that very highest, most critical category. So we developed this in a very pragmatic manner, working with oncologists, showing them case after case of symptom trajectory. Would you think this patient needs more time in your clinic? Would you think, would this be a patient in that moderate category? Would this patient be in the low category? And so this was a pragmatic process of really quantifying how the algorithm would work. After we did that, we then did health system utilization research. And we said, okay, so in this 6-month period, we had 29,000 patients who had completed 62,000 ESAS-Rs. And we looked at all that data, and we found the symptom complexity in those 29,000 patients was actually really similar to what we had found in our other chart audit previous work. So 16% were in that high category, 19% were in medium category, and 64% were in that low category. Then because we live in Alberta, we have a very integrated data environment. I could then look at all of those patients and say, how did they use emergency room visits or admissions? And I limited the time period to 7 days because I really wanted to have some confidence that the interaction with emerge or hospitalization had something to do with the symptoms they had reported. So basically what we found was that patients who had medium symptom complexity, so that middle of the road, were almost 2 times more likely to have an emerge visit within 7 days of reporting those symptoms. And if they actually were reporting symptoms in the high category, they were 3 times more likely to end up in emerge within 7 days. And then the same kind of trends in admission, even more significant. So if they were reporting high symptom complexity, they were 4 times more likely to be admitted within 7 days. So this was super powerful to our oncologists and our clinicians because it started us on the road of really valuing the predictive capacity of patient-reported outcomes. Because if we could prevent emergency visits or admissions, we can save the health system more resources, and it's better for our patients if we're proactively managing those symptoms in the cancer outpatient environment than in that inpatient environment. And that's been published on as well. So after we found out that data, we're like, okay, so how do we make this accessible to our clinicians? How do we bring this to their fingertips in their practice? So we built it into what we call the clinic list. So in ARIA, there is the capacity to see whatever clinician can go in and pull up the patients that are coming into their clinic that day. And we were able to add a column that actually looks at the symptom complexity from their most recent reported symptoms, and we could put it in there. And again, not every patient needs more. So if I was an oncologist that had 20 patients in my clinic, about 4, 5 of them would be in that high symptom category, and about 8 of them would be at that moderate symptom category, and the rest of them would be in mild symptoms. So if you have to understand, okay, how about I focus more time on these patients and maybe the nurse is focusing more time on the low symptom complexity patients, or vice versa. It was up to the clinic on how they wanted to do that, but it was really about bringing the knowledge to their fingertips so they could make better choices about the dose of care patients were going to receive. So this was all in the ARIA system. We did do some kind of predictive modeling to say, can we forecast how many people will come into a particular clinic in that moderate or high category? And we were able to, was very stable, in surprisingly stable data in terms of that 15% being in that most complex category. So this all predated our moving into Epic. And so between 2017 and 2025 was really our work to integrate into EMR. And there was lots of delays because of COVID. It shouldn't have taken that long, but that was the case. So one of the things we did in that COVID era was we really, again, listening to our oncologists, and there was a lot of feedback that ESAS-R was developed as a palliative tool, and it wasn't as comprehensive in terms of general symptoms all cancer patients need to be assessed for. And so we did a bunch of engagement with our clinicians and our patients, and also literature review around common symptoms all cancer patients should be assessed for. And you can see at the bottom, we developed a new version of ESAS-R called the ESAS-R Cancer, and it has 6 new symptoms on it that are related to being a cancer patient. And I was just talking to Sylvie that they have actually integrated this into their Can Impact work. So it's already here in Quebec, which is great. And we have published on this, validated it, and it's being used in many places already internationally. So when we were building our tools into our Epic system, we integrated it as a questionnaire that patients we could set up in the EMR so that anybody that was coming for a consult or a treatment appointment, where they see the physician before they have their treatment appointment, or if they were coming for a follow-up visit, it was automatically attached to that visit type. So it wasn't like our oncologist had to remember to send the questionnaire. It was all built into the system. So our current state is that patients get an email 3 days before their appointment that says, you have an upcoming appointment at the Arthur Child Cancer Center. Please complete your symptom report prior to arrival. We have, so then patients can do it right there. There's a link, they do that. That information flows real time into the EMR, which populates into a new version of the individual trended dashboard that includes those new 6 symptoms. And so that data is there every 15 minutes. If a patient does this at home, it is updated within 15 minutes and it's part of their individual trended data. So currently, so we've been live since November of 2022, so just over 3 years. We have over 440,000 ESAS-R cancers since we went live. And that is, oops, wrong way. And that is for about 81,000 unique patients during that time period. So most patients complete between 4 to 6 ESAS-R cancers in a year, because they're coming repeatedly to us. And it's very important for us to consistently measure their symptoms because symptoms change all the time. And our ability to tailor care to the needs of the patient relies on us having a very strong mechanism to gather that information from patients so that we can respond appropriately. So I'll just give you a little bird's eye view of the Pro dashboard that has been built into the Epic system. So again, it's an individual dashboard that shows change over time for symptoms and using all those same rules of color coding. And there's links at various places within the EMR so that clinicians can get to that person's dashboard. And we also built it into the multi-provider schedule, which is what a clinic list is called in Epic. And you can see here an example of somebody who has green symptom complexity, an example of somebody who would be classified into that yellow symptom complexity, and a patient who would be flagged as high symptom complexity. So right off the hop, you can see it before the patient arrives because they've done this from home. You can click on the dashboard to see the unique elements that are driving that complexity screen. And this has been helpful to our clinical teams. So where are we? So we have achieved 70%. So in 3 years now, we now have 70% of our patients on the patient portal, which is remarkable within 3 years to achieve that. We have about 50% of our ESAS-R cancers are coming in completed by patients on the portal. So obviously there's continued work to do on that. For the patients who don't complete it on the portal, they still have the opportunity to have a paper form and it's entered into the computer. And on average, we have about 13,000 ESAS-R cancers a month across Cancer Care Alberta that are coming in. So how does this actually get us any closer to palliative symptoms? So this is the most recent piece of work I've been doing in collaboration with Dr. Sinaraja. So when we went live with Epic, we did something really innovative, which was to put in a force function for oncologists to declare whether a treatment protocol is curative or non-curative. So for those of you that know a lot about what's been going on in the cancer world, our ability to control advanced disease has exploded over the last decade. We have targeted therapies that really work by targeting those genetic mutations that have been shown to really stall or slow down the progression of cancer. We have immunotherapy, which really harnesses our own immune system's capacity to fight cancer, which again is very much targeted on when we can't cure your cancer, we could control it. And the combination of these with traditional treatments has transformed our ability to keep people alive for much longer periods of time because of ongoing treatment in the oncology space. So all of this has been very important, but if you can't identify the subset of patients that are in a curative state versus a non-curative state, it is hard to build the right programs of support, because when we're not going to cure someone, quality of life and supportive care is super important, because these patients with advanced cancer, they are going to stay on treatment for a very long time. And so access to supportive care is essential to help them live well. And so this was a step we took when we built our protocols in Epic. And it's a force function, so our oncologists have to declare whether it's curative or non-curative. It doesn't change what they can order. It's more just an indicator so that we can look at the data in our administrative data sets. And because we have this non-curative flag now in our administrative data set, we're able to analyze the data. So just recently, I've gone into the data and looked at the whole year of 2023. It was the first year we had full Connect Care data. So Epic, that Connect Care is what we call our Epic version. So 1 year of data, this new curative, non-curative flag is there. And we wanted to understand how often people are on treatment that isn't going to cure their cancer. And what did we learn? We learned that in that 1 year period, we had 8,000 unique cancer patients that had at least one non-curative flag in that time period. So, and we know that this might not be 100% accurate, in that there could be more non-curative patients, because radiation oncology still documents in ARIA-RO, and so it's not a force function for our radiation oncologists to declare curative versus non-curative. So this is primarily medical oncology patients. And of that 8,000 patients, we had about 10,000 flags in total. So some patients were getting more than one non-curative flag. And what that means is that every time there's a new protocol ordered, there's a new flag. So as an oncology nurse with 30 years experience, I was like, why are we changing a protocol? Because people aren't doing well on that protocol. So we change it to another protocol. So I started looking at let's understand what's going on with sequential flags. And so we see that 74% of our patients who are in this category of non-curative only had one flag. So they get on a curative treatment protocol and they're good, they're stable. That's good, that's what we want to see. And then 20% of those patients have one change in a 1 year period. But 6% of patients had more than 3 protocols within 1 year of this 1 year that we looked at. And it's like, okay, let's look at this more. So of course, because we have the patient-reported outcomes being routinely collected, 87% of these patients had PROs already in their chart. So then we could say, okay, so what's going on in their symptoms leading up to this flag and non-curable treatment? So that's what we did next. We said, okay, so we want to understand, how does the number of new treatment protocols in the non-curative space impact symptoms? And so what we saw is this. So the full cohort, the first bar, says 41%. So remember what I said earlier about 60% of patients being mild? So we're just looking at moderate and high here. So basically, in the full cohort, it's the same distribution as in our data. But as the number of flags go up in that 1 year period, their symptom burden goes up. So the more different protocols a patient's been on, the more symptom dense their experience is. And so this has been the first time we've actually been able to see this data. And it really helps us. Again, it's not every patient, because some patients go on a protocol and they have stable improvement, but there are some patients where they don't have stable improvement. And so what can we do with this? This is really the final piece of my talk, which is around figuring out how do we use what we know now to actually build some flags so that we can alert our oncologists to patients that are having high palliative care needs. So this is what we are proposing to do. So this is really the work that Dr. Sinaraja and I are partnering on in his CCS grant. But we're proposing a tiered algorithm that can improve sensitivity and precision while being practical and user-friendly for clinicians. So the first best practice advisory would be flagged after a first non-curative flag. So when you're ordering a protocol for the first time, that's no longer curative, it's going to be non-curative. It is going to encourage the oncologist to have a goals of care conversation with the patient at that point, just to ensure that what we're doing is aligned with what's important to the patient. The second time that non-curative flag is triggered within a 3-month time period, because remember that graph I showed you is that the closer together those protocol changes and protocols happen, the more likely patients are to be having significant symptoms. There is a second flag that is to revisit that and also to review treatment choices with the patient to ensure they're aligned. And then obviously when they have moderate or high symptom complexity, there will be a flag that really encourages that referral to palliative services. So that's where we're at. We're going to be testing that in the coming months in a pilot, but we hope to build that right into our EMR going forward so that we can get the right patients to palliative services as soon as we can. And that's what I wanted to talk about.
Thank you so much. So I encourage people online to type in their questions if they have them, and I'll turn to the room to see who might have questions here for Dr. Watson. Samara?
That was an epic talk and an epic illustration of how patient-reported data can be used to provide services to our patients in a really timely and equitable fashion. I had a question about how distress screening and Canadian Problem Checklist is used in Alberta in combination with ESAS-R cancer, and if at all, and how that works. And I also wanted to know about the cutoff points that you showed to referral to services. How was that decided? Like specifically, like 4, 7. I'm interested, obviously, in psychosocial oncology, but all of them, how is that decided? And if you've revised them in any way, depending on services in the last year or so.
Okay, so I'll go with first question first. The Canadian Problem Checklist has been revised because as we redeveloped the new ESAS-R cancer, some of the additional items that we added to the scale so we could see change over time actually were the most commonly reported issues on the Canadian Problem Checklist. So they've been moved. And then we reorganized the domains to be aligned with referrals. So there's a functional domain that goes to referral to rehab. There's a psychosocial, which is more about anxiety and depression, which goes to counseling. We have like the practical needs, which goes to social work. We have like appetite and dietitian needs that go to the dietitian. So that's how we've changed it, and it's all built into the electronic system. So if a patient ranks any symptom above a 4 on the ESAS-R cancer, they automatically and seamlessly get their needs assessment. So we're just calling it a needs assessment, and that information is there. And then to the second question that you had, which is around the cutoff scores, what I would strongly tell you is that we did not do automatic referrals. Those are recommendations for clinical practice to make the referral. We did not go down the route of automatically referring based on a score, because the score needs to be contextualized to what's going on in the patient's life. And you also have to have a conversation with the patient around whether they want a referral to that program. So we rallied against automatic referrals from that context of just sending it off because there's a score. It is about reinforcing to the clinical team that this is where you should consider having a conversation with the patient about the referral you need to make. So no, they're not hard set. They are categories, and the clinicians need to use their clinical judgment. They are working well because they really are very much mirrored to our symptom complexity algorithm, which is really like when you get into that 7 to 10 category and all those symptoms, like you really need to take a different approach, because you can't do symptom management symptom by symptom. It's more global, like, wow, you've got a lot going on. How can we help you today? Maybe we should get the symptom management team involved because it looks like you're having a hard time with your quality of life.
Okay. Yes, one more question, and then there's some online. So please go ahead. And if you can turn on your mic, that would be great so people online can hear.
Hi. Thank you so much. Great talk. Do you see down the road you or your colleagues expanding this to neurology, cardiology, the different other forms of palliative care that we tend to do? I'm a home care nurse, that we do in the community.
Yeah. I actually have collaborated with rheumatoid arthritis, rheumatoid arthritis group, because it's so driven by symptoms that patients experience that then when the symptom escalation happens, they need to come in and have an assessment and get on steroids. So that group has been quite curious about how we've managed to integrate it into the EMR. But I would have to say that my role has been to advocate for it, but my scope of influence is really the cancer world. So I think that we are the envy of a lot of other programs in Alberta, because we're the group that has actually done the most in the space and are demonstrating, wow, this is powerful. Now people are lining up to say, how did you manage to do that? And how did you build it in the EMR? Because that's also been a huge learning for us.
Okay, I'm just gonna, Alan, go ahead.
I just wanted to thank you for this. This is fantastic work. I'm sure thousands of Albertans have benefited from it. So hopefully others can in other jurisdictions through this collaboration. We went through I was in Ottawa until recently, and when we were there, we transitioned from from a paper-based approach to an electronic approach. And one of the things we learned during that process, there was a couple of things we learned. One was it really disrupted the workflow. Yep. But as it pertains to PROMs, the paper was no longer, or the report was no longer sitting in front of the doctor or the nurse when the patient was there. So I don't know if you did any specific strategies or if you found the same thing.
Yes.
And then the second thing I wanted to ask was, the other problem we found was, like, when people did it on my chart, a lot of things that got filled on my chart, the clinician didn't look at those responses. So they're both kind of the same thing, but I wonder if you've dealt with that or found out how to.
100%. So we got a lot of feedback from the clinicians that they missed the paper form. Even though they complained all the time about the paper form, that it didn't have all the information, it wasn't that helpful, I couldn't tell what changed, it cued them to say, oh my God, you got a lot going on today, like, because it was right in front of them. So we did do a lot of, like I was telling Justin, that one of our biggest strategies around this work was change management. Because you have to actually address the people side of the change. You can build the best IT system, you can have the best data tools, you can do all that, but if the people don't change their workflow, it won't translate into benefits. So we have done a lot of work with clinical workflows trying to implement huddles where the clinic list is looked at before you start the clinic, because you actually have privileged knowledge now before you walk into the room and see the piece of paper. So it's like working with teams to help them reconceptualize their workflow so that there is a standard point at which the physician and the nurse are looking at their clinic together saying, okay, let's just quickly look at these dashboards. Let's look at our list and see how many are really having a hard time. And then let's divide and conquer and still come together and really strategize. So that's how we managed it, very pragmatically, very much at the elbow, working with clinical teams. Still lots to do. It's not perfect. I can stand up here and tell you we've done all this work, which we have. It's still not perfect.
So I'm going to go to some questions online. Someone said, though, which reflects, I think, a lot of the murmuring during your talk, which is that we're green with jealousy of your integrated electronic health system. We're still so paper-based. Wonderful talk. Thank you. One person asked just a simple question. Is there a way to get the ESSR that has the extra questions on it?
Yes, yes. It's completely open access. We've published on it, and it's validated. And I've been getting emails from people overseas that want to validate it in different languages and do all that work. So I'm happy. It's free access. So I'm happy to share it. My email's on the screen, or you can look it up under just Linda Watson, 2025 ESSR validation, ESSR cancer validation. You'll find the article.
Great. Another question. Have you utilized oncology nurses to employ evidence-based symptom management approaches for patients versus referral to other clinics?
Absolutely. So I think back to that beginning slide where I had the ESSR and it was like clinical practice over here, and then when to make a referral. Much work happens in clinical practice. And we have been using CoSTARS as a symptom management guideline. That's Pan-Canadian Symptom Management. And it's developed out of U Ottawa, Don Stacy. But I think in general, this has really augmented nursing scope of practice, like really situating symptom management in the nursing space. I didn't talk about it here, but we also have a implementation science study going on right now using all of the tools that we've built in our EMR to do remote symptom monitoring between clinic appointments, because now we have the mechanism to get data from patients. And what we're finding, and we have nurses that are using our symptom complexity algorithm to then flag which patients they need to call and do a symptom management intervention. And what we're finding in that data, it's still early days. We have about 100 patients on the remote symptom monitoring study. In that study, it's showing 85% of the time the symptoms are manageable within a nursing scope of practice. And 15% of the time is very appropriately symptoms that we need to collaborate with the oncologist to manage. Bowel obstructions, new brain mets being identified, anemia, a variety of things that are being identified proactively early so that we can intervene early.
So there's so many good questions online. So I'm trying to consolidate where possible. One question relates to palliative care capacity to see identified patients and whether or not you involve primary care in the provision of palliative care, especially as many of your patients live in outlying areas of the province.
It's a good one. So what we are trying to do actually to increase the capacity in palliative care is actually upskill our oncology teams to do primary palliative care within ambulatory oncology, because an early palliative approach to care includes impeccable symptom management and managing things that are within our scope of practice, which is what PROS actually leads us towards. And so you will see in my proposed algorithm, it's not every patient who has an advanced cancer diagnosis needs to go to palliative care, because that would be unmanageable. In that 1 year data, that's 8,000 patients. That's unmanageable. We won't have enough palliative resources for that. But we in the cancer program need to start having those conversations and doing the first steps so that when their symptoms escalate and they're in that non-curative place, we are actually flagging those most importantly urgent patients to have more. And then we'll build back from there. It's not to take anything away from earlier palliative involvement, but we also can't sink the system by sending everybody over, because then it would be just like automatic referrals that you asked about with the cutoff scores. We would just swamp the palliative team. So we need to find a balance where we're all managing it together.
From your experience, what are some of the most important lessons or recommendations you have for those interested in integrating PRO measurement in institutional EMRs, and how do you stay motivated during prolonged periods of swimming upstream?
Yeah, I was born, I don't know where that came from. So I just have to declare I'm a very strange fish. I love challenge. I'm pretty persistent. I think building a team, getting people around you, because you can't do this work alone. It's hard work, and you need to have that sense of progress. So what I have learned is use data. Like, I am a qualitative researcher. My PhD was qualitative research. I am now so deep in quantitative data and being able to pull data up and say, oh, by the way, 25% of our new referrals are late stage at diagnosis. Did you know that? And people just stop. And they're like, no, I didn't know that. Well, it's in our data, but we need to start using data to drive program development and scoping out what programs we need. So I'd say get literate in the data, invest in a data analyst so that they can feed you the right data, look for trends, look for these things that we don't know yet. And then I would say be pragmatic. Design your intervention to meet the needs of your clinical teams, because if you can do that, which is what I really focused on, how do you want to receive the data? Okay, let us see if we can do that. And then bring it back. They're like, oh, you did exactly what we needed. And it's like, yes, because this is a service to our clinical team so you can understand your patient's symptoms. So that's what I'd say were my big learnings.
Super. Can you speak to the processes you used to train and educate providers and patients when you rolled out your ePro system? What training tools or mechanisms were used? Did you use in-person training, online modules, written materials, videos, etc.? And who provided that training?
All of the above. We did multiple modality training, and it really focused in on how to have the conversation about the symptoms. So, and how to use the information to advocate on your patient's behalf with your oncologist. So our training primarily focused on nurses because they were doing the initial review. And we used, like I said, we partnered with clinical educators. So we integrated into orientation. It's part of everything that when new people are onboarded, this is part of the training. But then we also did at the elbow supports in clinics with the whole team, oncologist, nurse, and the EMR to show where you could find things and how to use it. And we've been doing a lot of work on the huddle implementation because that seems to be the biggest mind bend, is finding time as a team to look at something together and then using this pro data to really define how are we going to meet the patient's needs in the clinic.
Thank you. I'm going to come back to one final question in the room and encourage people who have unanswered questions online to email Linda directly, if that's okay, at the email address here. Virginia?
Hi, Linda. Thank you so much for your talk. I think this is a plug for nursing research. This is what nursing research is, or one aspect of it, and it's an exemplary example. And it's also nice to see the evolution, to see the from 2012 to now. So my question relates to the roadmap that you're actually providing to us. There's so many of us at the MUHC who was working on and interested, and many of us are in the room about PROs embedded and how we get to the electronic records. So I'm glad that Dr. Forster is here too, because, but I want you to go back to 2012. We're still in a paper-based format. We are collecting some measures electronically, but by no means are we sharing, and we're still working in silos between different departments. When you bring yourself back to 2012, what are some recommendations can you provide to us while we're still in the paper-based format, and how can we prepare ourselves for the eventual epic that's coming?
And I think that goes to the question that the gentleman in the front row had about what do you do when the paper disappears? And so my worry when we were going live in Epic and we were going to go digital was that if you didn't have an existing workflow that already existed where staff were actually looking for patient-reported outcomes because they were already socialized to say, I need to have a conversation with the patient about what symptoms they're experiencing. So I need that information because it's part of my practice. So that's why that problem was not as significant because they actually then were open to learning a new way to find that information because we'd already established the practice. So I would say seize the opportunity, focus on the use of the information in clinical practice to make good referrals to supportive care.
Okay, thank you so much. This concludes the second Balfour Mount lecture sponsored by the MUHC Foundation here in Montreal. We're so grateful to you, Dr. Watson, for your expertise and time with us today. Please complete your evaluation form, which you can access by this QR code or that will be sent to you by email. And we look forward to seeing you again on February 18th when Dr. Nadia Collette will speak at the Teresa Deller Palliative Care Residence on her experience with art therapy. Thank you so much, everybody. À la prochaine.